for setting that up. And sorry, I'm not actually going to speak to you about Sri Lanka. I was going to go to Sri Lanka, and I think you said earlier, the only reason people don't go places is if the government says you cannot go, and the government said you cannot go. So we didn't go to Sri Lanka. But I was very grateful to be able to go to Tanzania. And I'm really grateful for the support I had to go there. Like everyone else said, I wouldn't have been able to go otherwise. So very grateful. And I went to Dar es Salaam to Muhimbili National Hospital. So I was primarily based in the emergency department in the resus rooms, and I'd quite like to speak to you about some of the differences in healthcare that I saw while I was there and speak through some of the cases that I saw as well. But before I speak about some of the things that were more challenging, I also want to speak about some of the things that I think they're arguably doing much better than we are, and we definitely have a lot to learn from them. So this was one of the resus rooms where we were based. There were 4 rooms in a corridor, and a big rubbish pile at the end, which we'll come to later. That was important. But first of all, one of the things that Tanzania do so much better than we do is their reliance on investigations is so much less. They do clinical reasoning way better than we do. If they think they're not sure what a diagnosis is, they can't just order a CT or an MRI to see what might be going on. They take a good history, they physically examine, and they have to just trust their diagnosis, which was very challenging and something that I think I had a lot to learn from, and that was really valuable to see. They also had to rely on their team a lot more. When they have a difficult case, they have to discuss it and decide, okay, well, what do we think we're going to do about it? Because we have no other way of finding out. We can't just do some bloods. I'll talk a bit later about the way that it's financed, but every single test you do, the patient's paying for that. And if the patient says, I only have this amount of money to spend, I can't have these blood tests, then we're not doing the blood tests. So we have to work out what we think is going on. But like I said before, the difference in resources was stark, and these are not very good photos. These are not photos I took, but this is the closest I could kind of get to try and show what we were dealing with. So a lot of what we were dealing with was trauma management, a lot of road traffic accidents, a lot of motorbike accidents, and we saw a lot of query C-spine injuries and broken arms and legs. So the way that we would deal with this is the photo on the left roughly shows how we deal with a query C-spine. So you get 2 towels, roll them up either side, big roll of sellotape, and tape their forehead and tape their chin. I was actually in York A&E last night, and we immobilized C-spine. It didn't look like that. And to be fair, this was not as good at immobilizing their neck, but it was quite impressive to see what you can do when you don't have anything else to do it with. It does a pretty good job. And on the right comes back to the rubbish pile. So in A&E, there's the 4 resus rooms, and then there's the recycling pile at the end. So when a patient came in with a broken leg, one of you would totter down to the recycling pile, get a cardboard box, rip it up, make a splint, and there you go. You've got your splint. Again, not quite as effective, but definitely quite the other end of the spectrum to the NHS, where we basically use everything once and throw it away. And there's definitely something to be learned from how many resources could we be reusing and making better use of that. So I've got 2 cases to speak to you about. The first case I'm going to speak about was a gentleman who came in with electrical burns. So funnily enough, at the time of when he came in, I'd said the wrong word. I'd said it was quiet, and I was standing in quiet resus with the doctor, and we were talking through the A2E, and then this gentleman came in and he said, right, okay, A2E, off you go. Oh my goodness. The gentleman had been standing on the top of a lorry and had reached above his head and touched an electrical wire and just burned all the way through him, and his skin just shed off him like a snake. I can't really do it justice here, but the orange areas are where he didn't have any skin left, and it was just flesh. So his observations on arrival are on the left, but essentially just, it wasn't looking good. And the problem was that when you don't have any skin, you can't put a cannula in, you can't get an arterial line in. There's really not very much you can do. So back to the A2E, all we could really do was try and ventilate him. So my job was to stand there and bag him and try and help with the breathing. And we worked on ventilation for about 2 hours, and then unfortunately he sadly passed away, and there was nothing else we could do. But it was one of those that kind of made you think about, okay, what are the differences in resource management here? What do we have, what do we not have, and what can we deal with? So we didn't have the option of ventilators or ICU. A lot of the equipment is faulty. So it was quite frustrating when sometimes you felt like, I'm actually not helping clinically here. I'm a mechanic. I'm trying to fix the ECG machine. I'm trying to fix the bed. That was a bed I was trying to fix because the wheel had come off anyway. So yeah, that was quite a tricky thing when you've got a really sick patient in front of you and you're going, actually, I'm not helping clinically here. I'm just trying to get things basically running. And the other thing which was mentioned earlier is that when you have limited resources at your hands, things like maintaining dignity and privacy are quite difficult. All of this was happening in a shared bay with other patients who were completely alert. There's no screens in between. They know exactly what's going on. And even things like we then verified the patient's death. And for quite a few hours afterwards, they are all just in a shared bay. And it's really tricky to try and care for everyone in that same bay at once when that's going on. And the second and final case I'm going to speak to you about was by far the most heartbreaking case I saw. A 60-year-old gentleman presented to resus with central crushing chest pain, and the ECG on arrival showed that he was having a STEMI. The payment system in Tanzania is a sort of a combined one. So you can either have health insurance, which is very rare, or you can do it by private payment, which is how most people pay for their healthcare. So for most people, they'll arrive at the hospital and it's then the patient's family who pay for their healthcare. And that applies even in emergency situations. So when someone comes with a heart attack, they go to the patient's family and they say, okay, you need to go to the pharmacy, buy the aspirin, bring it back, and we'll give it to the patient. Unfortunately, with this patient, we just couldn't get hold of the family, which is really heartbreaking because he was within the windows for medical and surgical treatment, and there was just nothing that could be done. So he was just left lying in resus with no treatment at all. It was really frustrating because you think things like this still happen when patients don't get treated just because they can't afford to pay. And in this case, maybe he actually could have afforded to pay, but we just couldn't get hold of his family. And I don't even want to think about how his family would have felt when they finally got in touch with him. But anyway, we have many gripes with the NHS, but they sort of pale into inconsequence when you think about the fact that we still have healthcare free at the point of access. So I'm very grateful for all of the opportunities that I had and the ability to go out to Tanzania. There are so many more cases that I could have spoken about. But yes, very grateful for the opportunity. And if anyone has any questions, be very happy to take them. So the question was, why couldn't I go to Sri Lanka? That's a great question. So I originally was planning to go to Kandy in Sri Lanka. And it was around that time that the government building, essentially, there was like rioting in the capital in Sri Lanka. And so the UK government advised against travel. And so the university said that's not recommended to go.
Yeah. Is there a two-tier system, or was this the best that Tanzania can offer, or is there another sort of layer of healthcare?
So this is quite an unusual hospital because it was in Dar es Salaam, which is not the capital, but it's the biggest city. And the reasons why it's not the capital are, I'm told, very political and complicated, but it's definitely the biggest city. So to have a hospital that does have some kind of insurance system is quite rare. Most hospitals are much smaller and are all through private payment. There are a handful of charity-run hospitals around the country where you can get free healthcare, but they are very few and far between. And I was told the vast majority of patients would never be within reach of one.
Can you talk about the case that you were talking about, therapeutic using aspirin and contact the patient, in contact with the patient's family? And how much would that cost just to go on that aspirin? What in terms of number, do you think that how much would
sorry. Yes, repeat the question. Sorry. The question was, how much would it cost to just go and buy the aspirin? I asked that question because I was really upset. And I said, can we just go and buy the aspirin or anything? And I was told, firstly, no. Secondly, it would have cost the equivalent of about £1.50. But no, we couldn't, because, and I do understand, essentially the doctors were saying, if we do that for this patient, we do that for the other 300 patients that are in the waiting room, or, you know, in the road. So you can't, but yeah, a disappointingly small amount of money.
Just being a geriatric doctor here, what I'm asking is, have you changed? Are you going to change your practice? And the fact that our teaching used to be, and I was taught as a medical student, that you make your first diagnosis from the history, you then correct it or improve it from the examination, and then you confirm it with investigations. Are you going to change your practice?
So the question was, will I change my practice of sort of clinical reasoning, I think? The answer is, in an ideal scenario, and if I am being the best medical student I can be, I would 100% do it that way. And I would take a good history, take an examination, and go with the investigations based on that. The answer is that, honestly, I am so scared of making the wrong decision, because I'm not even a doctor yet. I think the inclination to just go, I'll just do some extra bloods just in case, or why don't we just scan them just to see, because I might have missed something, that's probably my honest answer. Is no, I mean, I will not do that, because yes, I forgot there was someone from HIMSS in the room.
By your investigations, but don't, you must still, because it's more interesting if you make your diagnosis. It's challenging for you, and it makes you, I think, sometimes a better doctor when you've actually made your diagnosis. It's lovely to see the investigation and say, told you so.
Yes, I will try and be brave and do it properly.
I would just point out that is exactly how we do teach them to do it.
No, they do, yeah. And in my OSCEs in 8 weeks' time, I will do that, I promise.
But would they not consider some kind of charitable person within the hospital where you could, in an emergency approach, do like social care? You need £1.50 for aspirin.
So the question was, is there any kind of means testing within the hospital, or any kind of charitable? Unfortunately, no. I don't know, to be honest, whether they thought of it. But it was completely standardized, and it was quite stressful, because they pay for every single thing. So if I miss a cannula, they pay for that extra cannula. Which, yeah, I know, wide eyes, and I miss cannulas. So, you know, it's just everyone pays the same. There is a standard price for getting your full blood count. There's a standard price for getting an X-ray, and there's no kind of means testing within a government hospital. Like I said, there's a handful of charity-run hospitals, but within those government hospitals, there's no kind of tiered system for that.
What sort of hours will the doctors work in the hospital? The doctors are there all the time.
To be honest, what kind of hours do the doctors work was the question. To be honest, quite similar to here. They were normally 10 8-hour shifts, and there were doctors who normally did days, doctors who normally did nights, and then they'd rotate. The thing that was quite confusing to me was that all the doctors speak to each other in English, and all the nurses speak to each other in Swahili, and the nurse ward round is done in Swahili, and the doctor's ward round is done in English. And that is quite difficult when it comes to communication between the two sets of people. So the nurses don't speak any English, because why should they? They train in Swahili, they practice in Swahili, but the doctors are not allowed to speak Swahili. And if they were caught speaking Swahili, they got told off, and they said, no, we speak in English, if the consultant would catch you speaking Swahili. But often that was almost to the detriment. You almost thought, well, why don't you just speak in Swahili, because you will speak it fluently. And sometimes you felt like actually you're misunderstanding each other, because you're trying to get the doctors to speak to the nurses, and actually if you spoke the same language, this would be so much easier to get the team working together. That was a tangent. Yes, the shifts are quite the same as usual, except that the medical students are counted as staff when they get to 5th and 6th year, but other than that, it's quite similar.
Question. Last one.
Keep on the same thing, like how you were telling us what you learned there. they want to know what, could you have suggested to them, that why don't you just all speak in Swahili, or why don't you have
The question was, could I have suggested different ways for them to do it? No, that's a really good question. I'm sure there are some members of staff who probably are so humble and so open to hearing suggestions. Whether or not individual members of staff would be able to enact change on a hospital-wide level or a department-wide level, I don't know. I had some really interesting chats with individual members of staff about things. I hardly have enough of a backbone to do that. I would never have dared speak to someone in charge of, that's definitely a fault of mine. I'm sure someone who is more qualified and able to have those conversations, 100%. It's really difficult when it's a systemic issue and you feel like actually there's an issue with the payment system in the whole country and definitely the whole hospital. I don't know who the right person is to fix that. Maybe I should have said something, but certainly as a lowly medical student, you feel like I have not got
not at your level, but maybe something.
Probably and possibly. And there were definitely doctors there who had aspirations of traveling and working in other countries when they built up a bit some funds to do that. And I spoke to people who were saying, I want to come to England, I want to see how you work there, and bring things back. So there's definitely an aspiration for change in some of the staff, but it's hard to know what's the right way to go. We're certainly not doing everything right, so it's hard to know, really.
Okay, thank you very much, Deborah.